Thank you, Tejas. Hello, doctors. I am Dr. Rahul Mandlik from Shalina Healthcare, Dubai. I would like to welcome you all for this webinar. Today, we are going to discuss about H. pylori infection, which is one of the most prevalent and common infection across Africa. Let me also extend our warm welcome to our today's speakers, Dr. Philip Abraham and Professor Samaila. Before we move for the actual session, let me just quickly take you through our corporate profile of Shalina Healthcare. Today, Shalina Healthcare is one of the largest pharmaceutical companies across sub-Sahara Africa. And from last 35 years, we have made it our mission to make available affordable medicines across sub-Sahara Africa. And we achieve this by manufacturing our own products at our WHO approved facilities in India. And we also partner with many government institutions, pharmacy boards, as well as NGOs to roll out health education and health screening camps across different countries in Africa. That includes deworming camp, antenatal camp, and malaria detection camp. Along with this, we strongly believe that for doctors, pharmacists, and for nurses, education is not just limited to the college degrees or university degrees. It is like a lifelong process or lifelong learning process for them to deliver effective and informed care to their patients. So, to support our healthcare professionals across Africa, we have been conducting continuous medical and continuous pharmacy education programs since many years. And under this heading of speed, that is Shalina Professional Engagement and Education, we have started conducting educational programs offline as well as online. We have opened our own Shalina Learning Centers in different countries where doctors, pharmacists, and nurses are coming to get updates on the recent advances in the therapies. And under the same banner of speed, we have also started online webinar series, and today's webinar is the 6th English language webinar. So with this, let me take you to the actual session, scientific session on H. pylori infection, where two eminent and internationally renowned speakers and subject experts are going to share their views in the management and diagnosis of H. pylori infection. They are going to share their views with African and international perspectives. Dr. Philip Abraham, who is currently a consultant gastroenterologist and hepatologist at PD Hinduja Hospital and Hinduja Healthcare Surgical, Mumbai, India. Dr. Abraham is a retired professor and head of Department of Gastroenterology at KM Hospital, Mumbai. Sir is past president of Indian Society of Gastroenterology. He is also past president of Indian Motility and Functional Disease Association. He is recipient of Lifetime Achievement Award from Indian Society of Gastroenterology. He is a past editor of Indian Journal of Gastroenterology, and he is author more than 100 original publications in index journals, and he has delivered many orations and lectures in national and international gatherings. And with us, we have Professor Samaila also. Dr. Samaila is a professor of medicine and consultant gastroenterologist at Department of Medicine, Bayero University, Aminu Kano Teaching Hospital, Kano, Nigeria. And Dr. Samaila's areas of interest are gastrointestinal endoscopy, H. pylori infection, peptic ulcer disease, and functional gastrointestinal tract disorders. Dr. Samaila has completed residency training program of West African College of Physicians and was awarded with fellowship in 2002 from the College of Gastroenterology of West African College of Physicians. And he has also got fellowship in advanced endoscopy training at the University of Witwatersrand, South Africa. And Dr. Samaila is also acting as an external assessor to many universities in assessing their staff for the promotion. He has got many publications in local as well as international reputed journals. He has delivered more than 100 guest lectures, presented scientific papers and seminars nationally and internationally, and Professor Samaila is recipient of many meritorious awards. So now, without wasting much time, now I would like to hand over the session to Dr. Abram. And dear doctors and pharmacists, while you attend this webinar, if you have any questions, please feel free to post them, which we'll take up during question and answer session after both the presentations. Thank you.
Do I take over, Rahul?
Yes, sir, please.
Okay. Thank you so much, Dr. Mandlik, for those kind words of introduction. It's indeed a great privilege for me to be on the same forum as Professor Samaila, as you know, a highly respected figure from Africa, Chief of Gastroenterology at one of the biggest universities in Nigeria. Good afternoon, my dear friends in Africa and those of us who have joined from India. We're going to spend the next few minutes on unraveling some of the mysteries of this ubiquitous organism called Helicobacter pylori. My job mainly is to set the stage for Professor Samaila to teach us more about this condition, particularly in the context of the African scene and how it fits in with the international scene. We, of course, have a lot in common between India and Africa. So much of what I talk about from India will be applicable to Africa as well. And I'm looking forward to the questions that Dr. Mandlik will be forwarding to us. And I do hope that we can manage to answer most of those questions. So if you give me a minute, I would share my screen with you. Is the screen on, Professor Mandlik?
Not it, sir. Yeah, it's coming up.
We can?
Yeah.
All right. So we've gone through this. We've gone through the formalities and the introductions. I just want to clarify that I am indeed a consultant gastroenterologist at one of the corporate hospitals, a tertiary level hospital in Mumbai, and one that has made big scenes all over the country because of our deep interest in clinical care as well as in research. I'm sure Professor Samaila will share the same experience with you. Now, those of us who think that the story of Helicobacter pylori started just 2 or 3 decades ago must remember that the first identification of what they called spirochete-like organisms in the stomach was over 100 years ago. Japanese researchers from South America and parts of Europe had identified some microbes in the stomach, but did not know their relevance. The entire idea was crystallized when these two Australian researchers, Barry Marshall and Robin Warren, described the role of Helicobacter pylori infection in a serendipitous discovery in their laboratory in 1982. They first described the association between this organism and gastritis. Of course, when they extended that to talk about its role in ulcer disease, the entire medical fraternity took it skeptically. No one believed them at first. There was a lot of skepticism because we've been hearing about these kind of organisms for close to a century. It took over a decade, 1994, when the United States National Institute of Health Consensus Development Conference first recognized that this organism has a link with ulcer. And it was another 2 years before the US FDA approved its first antibiotic therapy for ulcers caused by Helicobacter pylori. This, of course, was followed by a lot of activity, and the CDC and other government agencies in the US then took up this job of educating health professionals about the link between this organism and ulcer disease. And now we know its role in several other conditions, not just in ulcer disease. The climax, of course, came in the year 2005 when Marshall and Warren were awarded the Nobel Prize in Medicine or Physiology. That was in 2005, more than 2 decades after their landmark discovery of this organism or rediscovery of this organism and establishing its role with the ulcer disease and later with other diseases. Now let's look at the epidemiology of this organism. You could see from this map that a majority of countries in Asia and Africa have been listed as high prevalence countries. You can see sub-Saharan Africa, much of Russia, the Central Asian republics, India, and all of South Asia and Southeast Asia have all been reported as high prevalence for this infection. But whatever we say about our data collection, we should remember, as this slide shows, that from several areas, including from Africa, from the Middle East, South America, some countries, the data are unclear. What can we say about the distribution of an organism in a whole population? Like for India, for example, we have 1.3 billion people. And then we test a few hundreds or a few thousands and say, this is the prevalence. So obviously, much of what we talk about prevalence figures is unclear and is based on our deducing from the data that we have in hand. But in general, what we need to know is that the developing countries have a higher prevalence of this organism as compared to the developed countries, which makes it the most common chronic bacterial infection in humans. That's interesting. Let's look at the pattern of acquisition, and here you can see that there are two distinct patterns. On the left side, that is the one that's colored beige or brown, we see that in developing countries, 80% of the population has been exposed to this organism by the age of 20. 80% have been exposed by the age of 20. In developed countries, on the other hand, at that age, it's less than 20% exposure. We moved further towards the right, and what we see here in developed countries is a second peak. But that's actually an artifact. It's not that as you grow older, you're more likely to, that's of course a simple fact. But what we see here is a cohort that has a carrier state. That means in their childhood, when the hygiene was not as good as it is now, there was a high exposure rate. And that is why people above the age of 60 have been reported to have a higher prevalence in the developed countries. In developing countries, of course, after we reach 80%, it remains or it almost plateaus. What we're hoping for is that with the passage of time, these graphs will move towards the right. And that in developing countries, we'll have a graph somewhat like this. And this peak that we see in developed countries will move off the graph. That's what we're hoping for with improvement in hygiene. But as it is today, this is a stage. Of course, this was described by Marshall over 2 or close to 3 decades ago, but we still know that this is the pattern that is prevalent in the world. So like I said, what would be the time trend? And this is a very good article that's come from Kano in Africa, which talks about the time trend in patients. What happens as a country develops its hygiene scene? Of course, this was a study in patients who underwent investigation for dyspeptic symptoms. This is not the same as the general population. What we see that the dark green graph is from the year 1999. The light green graph is from the year 2012. So a difference of about 13 years between them. The distribution in the ages is roughly the same. In that it peaks around the age of around the 3rd or 4th decade of life. But what I want you to pay attention to is the right side of this graph. Those are the figures for 1999. Those are the figures for 2012. So as you can see, with the passage of just about 13 years, the overall prevalence has come down from 70% to about 45%. So that is what the passage of time is likely to do to the prevalence of Helicobacter pylori. As hygiene improves, as general standard improves, the developing countries will become more like the developed countries as far as the prevalence of this ubiquitous organism is concerned. Let's move on to the route of transmission. We still don't know for sure how this is transmitted, except to know that vectors probably play a very low role, if at all they do. Person-to-person transmission or person-to-environment-to-person transmission is the most likely route. So we have fecal-oral or oral-oral routes of transmission. The oral-oral, as well as for that matter, the fecal-oral transmission route is what accounts for the family clustering or the community clustering of this infection. This organism has been isolated, of course, from feces. We know that when we come to the diagnostic tests, from saliva, from dental plaques. And here I must say that one of the pioneering works came from a senior colleague of ours in Mumbai, late Professor Desai, who described or first isolated this organism from dental plaques. We also have data from some parts of Africa as well as from India, where this organism has been isolated from drinking water sources as well. So fecal oral transmission, human to human transmission is what we're talking about when we deal with Helicobacter pylori. Obviously, if you put this in context, you can see that if the developing countries are more likely to have a higher prevalence as compared to the developing countries, we should have recurrence rates also that correspond to the Human Development Index. So if you look down here, that's the Human Development Index, with 1 being the highest. As you go higher, you see that the prevalence rates come down, the recurrence rates come down. So as a corollary to the prevalence, we also know that the chances of recurrence are higher in the developing countries with lower HDI and lower in the developed countries with higher HDI. We have our own data from India. This was way back in the year 2000, two decades ago, where only 1 of 45 patients who had Helicobacter pylori eradicated developed a reinfection within 1 year, and none of 46 who had no infection earlier developed a fresh infection. So we have a recurrence rate at 1 year, or a reinfection rate at 1 year, of just about 2.5%, which fits in somewhere down here. That doesn't mean our Human Development Index is very high. It shows that in cities that have good supplies and a reasonable level of hygiene, not only is the prevalence rate lower, but recurrence rate also is lower. Those are our data from 2 years ago. Moving on to the pathogenesis of this infection, we know that every infection has 2 components to the pathogenesis, the bacterial and the host factors. When it comes to Helicobacter pylori, the major research has been on bacterial factors. So we have the colonization factors and the pathogenicity factors, and I'll take them in some detail before we come to the host factors. I'm going to show this graph again later. But let's look at these 2 components, the colonization and the pathogenicity factors. This is probably one of the most detailed studied organisms in the world today. There's been so much research. There is a journal dedicated to this organism looking at the pathogenicity. And why is that so? Because it's ranked as a significant cause of gastric cancer. As all other risk factors are coming down, this remains as a high risk factor for gastric cancer. So more and more research on it. And this becomes a prototype study for pathogenicity when we look at how an organism establishes itself as a pathogen in an environment. This is a classical prototype study. And you can see that most of these virulence factors that we've listed here on the left are known to us. Probably urease is the most well-known among all of them. But look at what it does. Urease helps to neutralize gastric acid. It actually induces hypochlorhydria and blocks acid secretion from parietal cells. The second group, flagella, allow this organism to penetrate into the gastric mucus layer and also helps to protect it from the acid environment of the stomach. The third, adhesins, they mediate the binding of this organism to the host cells. So many of them that are adhesins are now found in the Helicobacter organism. 4, mucinase and phospholipases actually disrupt mucus secretion or disrupt the mucus layer, what's called the mucus bicarbonate layer. So you neutralize the acid, you allow the penetration, you disrupt the gastric mucus to enable the bacteria to delve deeper or dig deeper into the mucosa. While it's doing that, superoxide dismutase prevents phagocytic killing. Catalase also prevents phagocyte killing. So the organism is actually burrowing in here while it's being protected from the acid. It gets inside, it damages the mucus, and while it's inside, it's preventing phagocyte killing. It induces vacuolation in the epithelial cells, allowing it to feed on these cells. And finally, factors that we don't know much about stimulate an immune response, which ultimately may induce death in gastric epithelial cells. So like I said, this is a prototype for study of how a bacterium becomes pathogenic. These are the virulence factors. All the factors, of course, have been listed in the previous slide, so I'm not going through that, but this is how the bacterium works in. Let's move to the right side of the slide. Let's talk about the immunological aspects. What does the host do in the perpetration of this infection? How does it try to fight it? What is the role of various components of the human's defense team in the progression of this infection? Now, we know that Helicobacter affects, let's say, 80% of the population in developing countries. Very few of them will develop disease. A bigger number may develop symptoms, but most of them will go as asymptomatic. So what is it that decides that one host is susceptible to the infection and can develop disease? We know that that is multifactorial. We've talked about the organisms factors. Let's talk about the host factors. There is the genetic susceptibility, polymorphisms of the genes that are involved in the H. pylori inflammation. Then there's the host immune system. Thirdly, we talk about the environmental factors. Maybe some of the condiments, some of the dietary items that we take in, maybe curcumin, maybe something else in our diet, something in our nutrition that protects us or protects a significant population from developing disease despite this infection. So we know these host factors. We also know these environment factors. We haven't paid attention to one factor, and that is ultimately Helicobacter is only one of several inhabitants in the stomach. What is the role of the concomitant microbiome in pathogenesis of Helicobacter? Does the resident microbiome of the stomach have a role in allowing this bacterium to become pathogenic or in protecting the host from pathogenicity? So we have our own data, and of course it's only part of data that's come from around the world that talks about the gastric microbiome and their interaction networks and how they influence the development of disease. I'll just share a little data from those. You can see that in our study, when we compared dyspeptics versus those who had no dyspepsia, all of them had Helicobacter pylori. One cohort had dyspepsia, the other cohort had no symptoms. And you can see that the distribution of the microbiota is so distinct between these two groups. So maybe the microbiome has a role in allowing the development of symptoms. You look at it from the other side, maybe this organism actually suppresses the microbiome in some host. We don't know what came first, but what we do know is that the spectrum of the microbiome is different in those who have symptoms versus those who don't have symptoms despite the presence of Helicobacter. And this is what we call a Shannon index. Briefly, what we're saying is that as the prevalence of Helicobacter pylori goes up, that means as the abundance of this infection goes up, the abundance of the concomitant microbiome comes down. So there is an inverse relationship between Helicobacter and the other bacteria in the stomach. What came first, what influences the other, we don't know. But what we do know is that there is an inverse relationship between the abundance of Helicobacter and the rest of the microbiome. So maybe our gut microbiome also helps in preventing infection. And this, of course, showing the negative network when Helicobacter pylori is at the hub and how its interaction with the various microbiome or various microbiota in their stomach has a role. What happens finally in those who have the disease? What are the possible outcomes? I want you to look at two parts of this graph. This is increasing acid secretion or acid production. The other is a passage of time. In childhood, we have the normal gastric mucosa. Then an individual develops the infection, which then becomes chronic. A majority may develop non-atrophic gastritis and then remain asymptomatic. Some of them will develop one of these two, that is antral predominant gastritis, high acid secretion leading to duodenal ulcer. The others will develop corpus predominant atrophic gastritis. This is non-atrophic. Here we have atrophic gastritis. Acid levels are not as high as in this group. You have low acid level, but there is atrophy. These patients may progress to gastric ulcer. So these are the ones who progress to duodenal ulcer. These are the ones who progress to gastric ulcer. You see the difference in the acid levels between the two. There are two other sinister developments. That is the development of gastric malt lymphoma, and the other is the development of gastric cancer. Those who develop atrophic gastritis then develop intestinal metaplasia that progresses to dysplasia and then to gastric cancer. So we know that H. pylori infection predisposes to not only duodenal ulcer, gastric ulcer, malt lymphoma, and gastric cancer. If we extend that logic, we would expect that countries that have a high prevalence of H. pylori should have a high prevalence of gastric cancer. Largely, that is true, in that the WHO has recognized Helicobacter pylori as a class 1 carcinogen. But there's another aspect to the story of what we call the Indian enigma or the African enigma, because these are two continents or subcontinents where the prevalence of this infection is high, but the prevalence of gastric cancer is low. We don't know why. Is it diet? Is it nutrition? Is it the environment? Is it the gastric microbiome? We don't know why. But there's no linear correlation between the prevalence of this infection and gastric cancer. So although the WHO, based on Western data, have classified this as a class 1 carcinogen, we don't seem to have that high risk in these countries. In addition to the damage done in the stomach and the duodenum, there are certain extraduodenal outcomes that have been attributed to Helicobacter pylori. I've limited these on the right side of the screen. Probably the ones that are most better identified are iron deficiency anemia, ITP, that's idiopathic thrombocytopenic purpura, and vitamin B12 deficiency. In all the other conditions that I've listed here, there is a suspected role, but we don't have concrete evidence for a direct role. But we do know that Helicobacter pylori is now incriminated not only in gastroduodenal diseases, but also in extragastroduodenal diseases. Let's come to the diagnostic test. And there we divide them into invasive and non-invasive, or with endoscopy, without endoscopy. So in those in whom an endoscopy is indicated, for whatever reason, we would prefer to have the invasive test. That means a biopsy test. A biopsy will give us two answers, a rapid urease test and histology. It will also give us the facility of culture, which unfortunately is tedious, quite a, difficult organism to grow. It's useful when we're looking at regional antibiotic sensitivity. So where an endoscopy is required, we generally fall for rapid urease test. When an endoscopy is not indicated and we just are looking for this infection, you can do that with a breath test, an antigen test, stool antigen test, or serology. In India, and I'm sure it applies to Africa as well, where the infection is so rampant, serology does not distinguish acute from chronic, present from past infection. So we don't use serology as a marker of current infection. We can use it as a marker of prevalence in the community. So effectively, for practical purposes, what we're using is the RUT, the UBT, and the stool antigen test. A little more about these tests. You can see these three tests that we're talking about, that all of them have sensitivity and specificity in the 90s. All of them have high negative and positive predictive value. So we use the urease test both before and after treatment. We can use the stool antigen test also before and after treatment. Of course, we need to have all the precautions. That means they should not be on PPI. They should not have received an antibiotic before this. So, but these two tests will give us good predictive value and are useful before and after treatment. The rapid urease test on the other side also gives good predictive value, but is less accurate after treatment. Because if the virus load goes down, and RUT may actually be falsely negative, of course, it needs an endoscopy, so it's an invasive test, but we generally don't use RUT for documenting post-treatment infection or persistence of infection. Finally, let's come to the treatments that I can hand it over then to Professor Samaila. There's been so many national and international conferences trying to give us treatment guidelines. In the last 4 years itself, we have the Canadian, the European, the American, the Irish, the Japanese, and we've just completed Indian guidelines as well for Helicobacter pylori. So if there are so many guidelines, obviously there's overlap among them, but the one that probably has taken the world's attention most is what we call the Maastricht 5 and or the Florence guidelines. The various treatment regimens that we have, we've given up the days of dual therapy. Those of us who remember from the 1990s will remember that the initial therapy was what's called a dual therapy, PPI and one antibacterial. We've long given it up because the response rates are very low. So today, the current regimens are what we call standard triple therapy, or bismuth quadruple therapy, or non-bismuth quadruple therapy, which is again divided into concomitant and sequential. So we have standard triple therapy, we have the bismuth quadruple, we have the concomitant, we have the sequential, and the hybrid. Sequential would mean that you use one group of antibacterials initially and another group of antibiotics or antibacterials later. Concomitant, bismuth quadruple and standard triple will use the same bacterial therapy, antibacterial therapy right through those 2 weeks. Now, I'm talking about 2 weeks because for developing countries, the recommendation is to prolong the treatment for 2 weeks, unless you have evidence that a 10-day therapy works. In developed countries, 7 days is accepted as adequate in most countries, but in developing countries, 10 days or 2 weeks in for ensuring that there is adequate eradication. Now, before we select an antibiotic, I want you to be aware of the various antibiotic resistant rates that we have around the world. Here are three antibacterials: clarithromycin, metronidazole, and levofloxacin. The hashed band is the one that says any resistance above this level will make this antibacterial low responsive, meaning we should think twice about using an antibacterial if your region shows a resistance rate that's above what's shown in these hash bands. So in most countries in the developing world, this is what happens. We have clarithromycin resistance, we have metronidazole resistance more than 15%, and that's where most countries in the developing world reside. So we need to have alternatives that are useful for where the clarithromycin and metronidazole resistant rates are high. And in those cases, we need to use the bismuth containing quadruple therapy for 2 weeks. Unfortunately, in many countries, including till recently in India, bismuth is not freely available, medicinal bismuth. So then we are left with concomitant or standard triple therapy. So when we have dual resistance, quadruple therapy is the preference. Non-bismuth therapy should use levofloxacin with amoxicillin and high-dose PPI. Rifabutin is another drug that has been recommended, not available in most developing countries, not in India for sure. Duration 14 days, unless previous data have shown that 10 days will work. If the second line therapy is also not effective, then the third line should be based on regional antibiotic sensitivity, with the caveat that in vitro sensitivity may not reflect in vivo sensitivity or resistance for that matter. Okay. Experimentally, of course, we now have the quintuple therapy, we have the high dose dual therapy, and some data to show that addition of a probiotic may help. In our data, where we use concomitant therapy without bismuth, because we didn't have bismuth, we had two groups with concomitant and sequential, and what we did show that concomitant therapy had a marginally higher response rate as compared to sequential therapy, as you can see in this graph. Similar adherence and adverse events, no significant difference between concomitant and sequential, but the concomitant therapy was easier for the patients to understand rather than having a sequential therapy. In India, the concomitant therapy is more expensive than sequential therapy. So approximately 15 euros for the full therapy regimen in India for concomitant versus 10 euros for sequential. But our current preference is concomitant because it's easier to understand and gives marginally better response. In India, with these therapies, 10 days has so far been adequate. Finally, before I wind up, how does the developing world differ from what is mentioned in the Maastricht guidelines? In India, for example, we do not recommend screening all dyspeptics for H. pylori. For an organism that is so ubiquitous, so rampant in society or the community, screening all dyspeptics for H. pylori has no meaning because the organism is present even in non-dyspeptics. Secondly, in functional dyspepsia, our prevalence rates are similar to that in the general population, simply because the general population has a high prevalence. So we don't recommend treating functional dyspepsia for H. pylori. That, of course, is open to discussion and even debate. Thirdly, while we talk about test and treat in the Maastricht recommendation, in India we follow the test, treat, retest strategy. That means after treatment, make sure that you have succeeded because of the high antibiotic resistance rates. As I said earlier, we do not recommend serology as a diagnostic test. This is how we differ from Maastricht. Finally, the fear of cancer, because of this so-called Indian enigma, the fear of cancer has not been a strong reason for us to accept eradication as recommendation, except in high-risk individuals. That means in individuals who have other risk factors, in individuals who have first-degree family members who are positive, in them, the fear of cancer is a legitimate indication for screening and eradication, not in the others. And finally, in place of metronidazole, with its known side effects, we have shown that tinidazole, the other imidazole, also works as well. So, ladies and gentlemen, our esteemed guests here this evening, this is an organism that has stolen the limelight over the last 3 decades. We've come a long way in our understanding of this organism. We've even had the original researchers being awarded the Nobel Prize for everything that they told us about this organism. But 30 years later, we're still scrutinizing the organism because we still don't know all the answers about this enigmatic organism. Thank you so much for listening. I know I have exceeded time, but I now hand over to my esteemed colleague, Professor Samaila, to take the stage. Thank you so much once again.
Thank you so much, sir. Yeah. Yeah,
Thank you.
To Professor Samaila, please. Yeah.
Thank you very much, Dr. Philip Abraham, for this beautiful presentation. Are you seeing my slide now? Okay, thank you very much. Are you hearing me?
Dr. Samaila, your screen is not shared.
Are you hearing me now? Are you seeing my slide?
No.
Dr. Samaila, your screen is not shared yet, doctor.
Is it shared down?
Yes, now it is shared. Please open the presentation.
Okay, thank you very much. Okay, thank you very much. Good afternoon, everybody. Nigeria is afternoon, and I'm sure different times across the globe. I'll be talking about Helicobacter pylori, the African and Nigerian perspective. Dr. Philip Abraham has taken us to learn a lot of historical background and a lot of pathogenesis, investigation and treatment of this very important bacteria. I'll take the outline of epidemiology in Africa, risk factors for infection and why we have this such high prevalence in this continent, the clinical features and prognosis of this untreated infection, which he has covered partly, diagnosis in low research setting like Nigeria. We talk about the treatment regimen, which he has covered present and future perspective, what should guide our choice in the developing countries, and the role of physicians like ourselves and pharmacists in this challenge, and conclusion. We all know that peptic ulcer disease is a common and sometimes debilitating condition with devastating sequelae. And traditionally, we know acid and pepsin and NSAIDs have been the main culprits over the years. And although the old adage of no acid, no ulcer is still relevant in our practice, the discovery of Helicobacter pylori in 1982 have revolutionized our approach to peptic ulcer disease and gastric cancer. And treatment armamentarium have moved over the years since this discovery. And although WHO in 1994 classified this bacteria as a class 1 carcinogen, we all know that the African and Indian enigmas we've had have made this condition to look at it differently in these two continents. Despite progress in diagnosis and treatment, antibiotic resistance and reinfection and recrudescence have been major drawbacks in addressing this bacteria. And up to today, no effective vaccine has been developed that has been approved for global use, even though some have undergone phase 1 trial. We have had globally that about half of the world population are affected, but as high as 80% in Africa due to childhood acquisition. And risk factors are usually age, poor socioeconomic and poor hygiene and overcrowding and certain other factors. And up till today, there is no unified African guideline, unlike the Maastricht or Florence consensus guideline of the European Helicobacter and Microbiota group. Now, why do we have this high prevalence in Africa? The prevalence in Africa is variable between countries and even within countries if you look at different populations. Majority of studies in Africa have focused on symptomatic subjects with about 80 to 90% prevalence rate. However, even in asymptomatic volunteers, we have reported prevalence of up to 80% in this part of the world, still confirming the African and the Indian enigma. High prevalence with low incidence of disease, particularly gastric cancer. We have different choices of screening tests used in these studies, and dynamics of the continent have reported different rates across Africa. But we know that averagely Africa is in the red, about the region of almost 90% in most of the countries, as well as Asia and North America. You can see Australia there is just about 20–30% prevalence. So it's a high prevalence, but the good news is that we don't have much of the serious sequelae like gastric cancer. In Nigeria, the average range is about 70–80%. And you can see South Africa also is in the region of more than 70%. Egypt, Ghana, Kenya, Uganda, Morocco, and even Gambia. So Africa is a hub for Helicobacter, and paradoxically, is not a hub for gastric cancer, just if you heard about the enigma. These are about 5 studies that are reported in Nigeria. And you can see, even among healthy volunteers, as far back as 1994, when Holcomb first coined the term enigma, they are about 80% prevalence. And Olushola in 2002 also got about 80% in controls. So it means that a lot of people carry this bacteria. That was why Dr. Philip was stressing the fact that having high prevalence is not a reason to eradicate this bacteria unless you have very big family history of gastric cancer among asymptomatic subjects. What are the factors favoring this high prevalence in Africa? We all know that age is an obvious risk factor, because most of us acquire this infection at the age of 5 during early childhood. But we have the geographical location, developing countries generally more than developed countries for obvious reasons, of low socioeconomic status, uses of unclean sources of water for drinking, overcrowding even at the family level of more than 2–3 siblings in the family, open defecation and use of pit latrines leading to contamination of surface water, poor waste disposal systems because of the fecal-oral transmission of this bacteria, prior antibiotic use in this continent, sometimes inappropriately, which drives resistance, leading to poor response to first-line regimens. Parents or siblings with family with history of gastric cancer or gastritis or H. pylori infection also predispose the siblings to infection. Then we have high problems with recrudescence and reinfection, because we have a lot of problems with substandard and fake medications, and also patient education and ability to undergo the 14-day therapy regimen lead to a lot of lack of compliance with recrudescence and reinfection. We have improper diagnosis in certain cases, like in health workers, where Philip warned about the using serology. And we have seen people from the primary and secondary care setting using serology to diagnose Helicobacter and giving the patient a lot of antibiotic regimen before they are even referred to the gastroenterologist, thereby promoting antibiotic resistance with recrudescence and reinfection. And even healthcare professionals are not spared, because studies have shown across the globe that high incidence among gastroenterologists and GI nurses, and also why you have more than 2 siblings, as I said earlier, are also risk factors. So what about the issue of African, and now we have had the Indian enigma. We have heard about the high prevalence and low incidence of disease. Holcomb observed the fact that at most Nigerians or Africans develop gastritis as the main sequelae rather than gastric cancer. And several studies decades after also corroborated this finding by Holcomb in 1992, published in the Gut edition of 1992, describing this enigma. And we have heard about the host factors, the bacterial factors, and the environmental factors from the earlier presenter, that we don't have to dwell on that. But in terms of sequelae, this interplay of host genetic and environmental factors determine whether you come down with antral pulmonary gastritis or the atrophic gastritis, and whether you go on to develop gastric cancer, multiple lymphoma, or duodenal ulcer. But I think the most dreaded complication that we fear all is the gastric cancer, the multiple lymphoma, and complicated duodenal and gastric ulcers. And these are the sequelae that, that particularly the gastric cancer, that create a lot of fears among patients and their relatives. So apart from this, we have heard about the fact that iron deficiency anemia, thrombocytopenic purpura, and vitamin B12 deficiency are the main proven extra GI manifestation of this bacteria. So many other associations that have not been yet proven scientifically, but are being postulated, like coronary artery disease, peripheral artery disease, Parkinson's, migraine, Alzheimer's, rosacea, and even diabetes and autoimmune thyroiditis have been linked with this bacteria. But ITP, iron deficiency anemia, and vitamin B12 deficiency are the ones that have been proven scientifically. There are so many, of course, indication for testing for this condition, which we have had earlier. And I have to warn here that even in Nigeria, the test and treat, the treat and test, we also tend to follow the test, treat, and retest strategy, because that's the only way we can identify true people that we have eradicated this bacteria in order to prevent reinfection and recrudescence. So the test and treat of the European strategy in this part of the continent will do the test, treat, and retest again to confirm eradication. And I must warn here, the use of whole blood serology using IgG, it shouldn't be used for diagnosis and should not be used for the confirmation of eradication either. And that has been a problem in this part of the world over decades, that physicians or caregivers at the primary and secondary care, as I said earlier, use this test wrongly to diagnose and confirm eradication. But we know that IgG antibody persists for more than 3 years or more, even after you have successfully eradicated this bacteria. So what are the strategies that we adopt? Of course, have to be the test, treat, and treat again in our setting. But we all know that once we have alarm features that include bleeding, anemia, early satiety, weight loss, vomiting, dysphagia, or dinophagia, or strong family history of first-degree relative with cancer, we must go ahead and stop the patient, because these are alarm features. And therefore, we must infront this in our practice to make sure that we screen for these alarm features in anybody that have dyspepsia, so that we don't treat them unnecessarily before we diagnose cancer at a later stage. What are the indications for treatment? We all know that duodenal and gastric ulcer, following gastric resection, multiple lymphoma, atrophic gastritis, of course, controversy about non-ulcer dyspepsia, as Dr. Philip have earlier said. We also don't treat for Helicobacter routinely in Africa or in Nigeria for non-ulcer dyspepsia. But patients with first-degree relative that have positive Helicobacter, even if they have only dyspepsia, we eradicate because of the fear. We have gone through the first and second line and rescue regimen by Dr. Philip. And but I want to bring the fact that in Africa, we have problem of poverty, we have problem of compliance, we have problem of wanting to push to the 14-day eradication regimen. And most people are living below the $1 per day income. And therefore, we have to look for regimen that have cheaper alternative, particularly the nitroimidazoles, either metronidazole or tinidazole, which has been shown not to be affected by the gastric pH a lot and has excellent pharmacokinetics and safety profile and tolerance among patients, in addition to the clarithromycin if the resistance is below 15% and amoxicillin. Luckily, in this part of the world, we don't have much problem with resistance to amoxicillin in this part of the world. So what are the main issues? Poverty, affordability. The average of cost endoscopy in Nigeria in starting up to $50 or $150, depending on whether you're going to public or private facility. And then the issue of indirect cost of having to access where you can have endoscopy has influenced that. So there's cross-resistance across each family of antibiotic, because if you have resistance to clarithromycin, it translates resistance to all macrolides. So you have to avoid regimen that contains all macrolides if there's documented resistance in the first regimen. The same thing with levofloxacin as a fluoroquinolone. If there's resistance to levofloxacin, you have to avoid because there's cross-resistance to other fluoroquinolones. And then there's also no cross-resistance between different families. So if you use a penicillin as a resistant, you can use macrolide or tetracycline because there's no cross-resistance between families of antibiotics. In certain conditions, you can increase the dose of antibiotics to overcome this resistance, particularly in clarithromycin and levofloxacin, particularly in metronidazole. But in levofloxacin and clarithromycin, you cannot overcome this resistance by increasing the dose and duration. So we must know that locally in Africa, we have rare reported incidents of resistance to amoxicillin and tetracycline. And even though there's no resistance to bismuth, we have problem with bismuth in this part of the world also because we don't have them, as Dr. Philip have earlier alluded to, in India as well. This is a resistant profile shown here. You can see a lot of resistance to metronidazole, levofloxacin, clarithromycin, and very little for amoxicillin. So we still have amoxicillin in our setting that we can fall back to, and the nitroimidazoles to go for either the concomitant therapy, which is easier to comply, as we heard earlier, as against the sequential because of the low level of education and compliance in our setting. But I think in this part of the world, the 14 days, which is more desirable, have to be balanced with the cost, because 14 days is more, but most of the patients cannot afford that. So 10 to 14 days, but 7 days definitely may the rescue regimens. So what are the things that should guide our choice of regimen? Antibiotic resistant profile. We have had earlier if resistance is more than 15%, you should avoid that group of antibiotics. Do you have allergy or intolerance or contraindication to these drugs? That should also guide the choice of regimen. Is the patient treatment naive or has experienced treatment with another class of antibiotics with reported results so they can avoid it in the second line? What are the patient's profile and clinical indication? Affordability and availability and patient choice sometimes will guide our distance. And then we must have UBT, urea breath test, or other non-invasive tests to confirm eradication. Unfortunately, most parts of Africa don't have the UBT readily accessible to the patient. So the physicians again fall back to erroneously using either the invasive test of endoscopy and repeat biopsy, or going back to serology, which is inappropriate. And we have had that once you downplay the bacteria in the gastric mucosa, even the UBT becomes less sensitive and less specific for confirmation of eradication. So we must make effort to get the urea breath test in our setting, which is non-invasive, that you can use to confirm eradication. And you can see these are average cost of endoscopy in Africa, in Nigeria in particular, about $50 to $150. And we know people live below $1 in a day. Histology costs about $10 to $20 in Nigeria, or Kano in particular, where I practice. UBT costs about $5 to $35 depending on where you are. Fecal antigen test about $5 to $10. Then the clot test or the rapid the urea breath test. Clot test is rapid urea test about $20 to $40, and then the cost of standard triple therapy is about $100. Or there are also some indirect costs because of transportation to where you can get care. So having looked at this problem, what are the ways we can prevent Helicobacter pylori in Africa? We need to improve our socioeconomic status, our level of hygiene, our standard of living, our daily income for average Africans. The health education, because it's collaborated with the level of hygiene and also propensity to infection and reinfection. Improve level of sanitation and human development index, as we have heard from Dr. Philip, is proportionate or inversely proportional to acquisition of Helicobacter. As the HDI goes up, the infection and reinfection rate goes down. So vaccine is still being developed, but I said it's not yet there for use. We must have prompt and accurate diagnosis where we interpret, and choice of drugs and diagnostic regimen must be carefully taken. For the treatment, we must know local resistant profile, and that's why our pharmacists, our microbiologists, and our clinicians must come together to document local resistant profile to guide their choice of therapy and even the duration, and make non-invasive confirmation tests available to most of our populace. We have heard about emerging things like probiotic supplemented regimen, which are still, but we have a critical role to play as healthcare providers. And I will take the next 2-3 minutes to highlight our role as healthcare providers in this journey. We need to educate ourselves. We need to educate our patients. We need to educate our clients and their family. So health education is very prominent. Capacity building about healthcare providers so that they will understand the right choice of diagnostic tool, the choice of antibiotics, the adequate duration, and be able to document eradication using non-invasive method. So this capacity building has to be there. Government and policymakers have to provide these facilities. Doctors have to be educated. Pharmacists have to be there to understand this challenge. Then we have to have prompt diagnosis method. And then we have to avoid unnecessary exposure to antibiotics, because some of them give antibiotics even before they send the patient for the test. There are parts of the Africa where people give triple therapy even without doing the test. And we must avoid that so that we don't breed resistant and end up with a serious problem or epidemic of gastric cancer, to reverse our natural position of African enigma or Indian enigma in the future because of promoting resistance to this bacteria. Optimal treatment and confirmation of eradication is very important. I would like for that to conclude by saying that the discovery of Helicobacter have revolutionized the management of PUD across the globe and also in Africa. But H. pylori remains highly prevalent in this part of the world. Clinical manifestation of this disease is still mild in Africa and in India because of the African enigma. But care must be taken among clinicians, pharmacists, and laboratory workers alike to make sure that we don't lose this advantage by breeding resistance using inappropriate diagnosis and inappropriate treatment in our patients. Factors favoring reinfection and recrudescence and reinfection are common because of our low hygiene, poor socioeconomic status, and inability to access the very expensive extended quadruple therapy or the concomitant therapy in some of society because of poverty. Triple therapy remains the gold standard still, but we should know that in this part of the world, the imidazole containing quadruple therapy or the imidazole containing triple therapy may become handy in Africa due to high level of poverty. and lack of accessibility for some of the regimens as compared to developed part of the world. H. pylori eradication regimens have kept evolving over the years, but antibiotic resistance is beginning to change our approach to the whole issue. And that is why we must have capacity building like this we are doing today, so that we can educate ourselves and re-strategize so in order to get a good outcome. Healthcare providers have a critical role to play in eradicating these bacteria. Still, no effective vaccine trial have been documented in animals and phase 1 clinical trial, but still there's no effective vaccine that has been documented. The concept of gastric microbiota is emerging, and Dr. Philip have touched on that, in the fact that the bacteria in the people that are dyspeptic tend to be more distorted compared to the asymptomatic population. So we must have this background of the emerging concept of gastric microbiota as we try to explore some of the gastric microbiota. Maybe they contribute to the gastric pathogenesis by synergistic action with H. pylori in our setting. Thank you very much, and I wish us a successful deliberation. Thank you.
Thank you so much, sir. Thanks, Dr. Philip, for such a precise and to-the-point presentation. I'm sure our audience will get very specific take-home messages today from your presentation, particularly for simplifying, rather decoding very complex pathogenicity in such a short time. And thanks, Professor Samaila, for providing us very grounded tips about H. pylori infection, which is so prevalent across Africa. And I'm sure the tips and the suggestions which you have provided, they are going to be helpful for our audience today. So now let us move towards the discussion part of the session, where I will take up some questions. Particularly, they are not addressed during the sessions, and I request both the speakers to please address these questions. So the first question is about the diagnostic side. Since the diagnosis of H. pylori is not as simple as like maybe diabetes or hypertension, and some specialized equipments are required. So considering the developing countries or some resource poor setups, which can be the gold standard diagnostic test in your opinion, whether it is a finger stick serology test or maybe a stool antigen test, considering the cost as well as the simplicity?
Okay, I shall answer that. Yeah. Okay. I think we have heard about the issue of serology, and I think nobody will promote serology for either diagnosis or eradication confirmation. You can only use it for population to document exposure of the population and prevalence in the population. So serology should never be either in a developed country or developed part of the world. But because of cost and ease of administration and non-invasive nature of this investigation, if you can get the urea breath test and the fecal antigen, I think those are the ones we should adopt across the globe because of the ease of application and non-invasive nature of them. But the suppliers of this consumable, particularly the urea tablet and the UBT machine, must come to the aid of Africa to be able to make it available at a cheaper cost, so that people can use the test, treat, and retest strategy in India and across the other continents of the world. Dr. Philip?
I would agree entirely with Professor Samaila that we also fall back on the urea breath test when an endoscopy is not required, urea breath test, but the capital investment is high. So for those who are not attached to corporate hospitals or do not have access to these machines, then the fecal antigen test, because that's done by commercial labs. So I entirely agree with Dr. Samaila, but how much we share with Africa, isn't there? I just had one extra line. When it comes to endoscopic biopsies and the rapid urease test, the commercial closed strip may be quite expensive, but it's not difficult to make these media on agar at home. Meaning you can have in-house development where you just need an agar, a urea base, and an indicator, and you can make an in-house urea kit, urease kit at a very affordable rate. We've done that in the public hospitals here in India.
I think I want to add something to that. As about 2 decades ago in Jos, north central Nigeria, we had Professor Agata that prepared this locally prepared the urea solution every time, because you have to provide fresh on the day you are going to use. You don't prepare it and store. So I think that's the only thing we need to think about. Is easily prepared by the chemist, and then you can use it and then prepare it on the day of endoscopy. I think it's a cheaper alternative compared to the commercially prepared clot testing.
Yeah.
Okay. Next question is specifically for Professor Samaila. Dr. Bello from Nigeria would like to know, considering the high prevalence in Nigeria and the rising resistance to antibiotics, what is the way forward now, particularly in the absence of national level treatment guidelines for H. pylori?
Yeah, I think for Africa, the Society for Gastroenterology and Hepatology in Nigeria, SOGIN, have produced several guidelines across many GI and hepatology diseases. And I think Helicobacter pylori is in the pipeline. I think the society have to come up with a national guideline. But in the meantime, need to develop their own antibiotic-resistant profile in local communities, so that you know that if you have high chlorophyll resistance, you should avoid and choose the other combination. And if you have high levofloxacin resistance, as documented in Kano also, you should avoid and go for the other alternative. I think that's what I would advise before the surgeon come with national guideline for local community to have their resistance profile documented and be guided by such.
Okay. Now, next question is about the lactobacillus. Like there are some sporadic evidences of the role of lactobacillus, maybe its action against H. pylori itself, or in the prevention of side effects because of antibiotic gastric side effects. So, what is your view, speakers, on the role of lactobacillus in the management of H. pylori infections?
All right. So what we have, I'll just first extend a little of the answer that Professor Samaila has given. As Professor Samaila mentioned in his talk, ultimately, for the long term, it won't be antibiotic therapy that will be the answer to Helicobacter. Prevention is the answer. And the second most important thing that Professor Samaila highlighted so well is misuse of antibiotics. If we didn't have this kind of rampant misuse of antibiotics, we didn't have to worry about bismuth quadruple or concomitant whatever. We could just get away with the triple therapy. So if we have these two things in place, good hygiene and avoid misuse of antibiotics, we will probably be treating them as in industrialized countries. But till then, of course, we have to have this problem. So I'm sorry, I diverted a little from there, but coming back to the probiotics, there is data. There are some data that say that the addition of probiotic may improve eradication rates, but that's not conclusive. Yeah. What we have more conclusive is that they reduce the side effects of the antibacterial therapy. So although now we have lactobacillus and some other bacteria that have been touted as therapy for Helicobacter, it's not a recommendation. It cannot be a recommendation as yet, unless we manage to get a probiotic that is specifically targeted to Helicobacter. At the moment, it's an addition, like people are added to any other antibiotic therapy, to reduce the side effect and maybe marginally improve the eradication rates, but not standard therapy.
Efficacy.
And
I agree with you.
Yeah. So, Professor Samaila, what is usually recommended duration of triple drug therapy in Nigeria or in African countries?
Yeah, the minimum duration is 10 days, but preferably 14 days. But the minimum duration shouldn't be less than 10 days. And preferably if you can go 14 days, it's better, but don't go below 14 days. Despite the fact that some have promoted 7-day regimen of some of the branded medication and some of the, but I think in Africa, because of this peculiar challenge of recrudescence and reinfection, and I think the 10-14 days is the preferred alternative. Yeah. 10-14 days.
Okay.
Again, can I add 2 subclauses to this? We should remember that the dynamics of in vitro testing is not constant.
Yeah.
In any country, like if you talk about Africa as a continent, it's a huge continent with so much heterogeneity. Same with India. We are actually a multiplex of communities, so many different communities coming together. So what I find in Mumbai may not be the same as what you find in Delhi or in India. So even within states or within countries, there's so much regional variation. So it doesn't matter what one center says may not be applicable in the same city to another center. So that's very important for us, number one. Number two, if something is resistant to clarithromycin today, it may become susceptible after 5 years.
Yes.
So unless you have an ongoing in vitro susceptibility testing, and each center has its own, we cannot tailor make the antibiotic regimen. So there, like Professor Samaila said, 10 days if you have evidence that it works. If not, to be safer, 14 days.
14 days.
Okay. Right. And both the speakers have mentioned about the strategy that is test, treat, and again test. So what is usually waiting period, doctors, after for the testing it after the treatment, and which test is recommended for the retest?
So the waiting period is 4 weeks after the end of treatment, and the patient should be off PPI for at least 2 weeks prior to the next test, and should be off all antibacterials for at least 4 weeks before the next test. And the standard test that we use is the urea breath test. What we don't use is the RUT, rapid urease test.
Okay.
The same thing here. The same thing, yeah.
Okay.
Thank you.
And talking about some local antacid products like maybe aluminum hydroxide or magnesium hydroxide based local antacids, what is their role, doctor? Is there any role of local antacids in the symptomatic management of H. pylori infection?
Yeah, I think the antacid, whether they contain alginate or not, and whether they contain antiform like dimeticon or simeticon, we find it as complementary to patients, particularly those that have bloating, gas bloating, and belching, and a lot of discomfort associated with it. They tend to give them relief because of the simeticon and dimeticon in some of these preparations. And I think those that have some predominantly reflux component also, with bile this in the stomach at endoscopy, if you ask the one that contain alginate, it also gives them some added relief. But I think these are not, these are just complementary, not as eradication regimen, but they help with symptom relief among this patient population.
So this will help to clear some of the misconceptions in the community. Like Professor Samaila said, it's not Helicobacter that causes symptoms. It's Helicobacter effect on acid secretion that causes symptoms. So when we talk about dyspepsia, of course, antacids will come in, not because they change the pH, not because they target Helicobacter, but because they take care of the acid peptic symptoms.
Yes, yes.
Right. And to Professor Samaila, considering the high prevalence and the lack of medical professionals, we'd like to know the role of pharmacists, maybe what role pharmacists can play, maybe practicing community or hospital pharmacist, in the prevention or management of H. pylori infections.
I think the pharmacists have a role to play across the globe, whether it be you academic pharmacies, hospital-based pharmacies, or community pharmacies. I think they have a critical role to play in this approach to address this bacteria. The issue of joining other scientists, doctors, and lab scientists to document the local resident profile. The pharmacists have to be there, central, to be able to document it, so that when they are doing the local hospital formulary, they should be able to know which antibiotics they will stock for the physician to use for eradication regimen. The other arm of it is the fact that, apart from importation, they have regulatory bodies, the Pharmacy Council of various countries. You make sure that the drugs produced locally and those imported within your country have documented efficacy confirmed in your local laboratory, so that the MICs are the ingredients that are in this, so that you don't import substandard or even fake medication in some instances. And the storage of this medication, so that on the shelf, so they don't become expired date is not yet there and it's no more efficacious. And also when they come to dispensing in the hospital setting, in the clinic setting, the pharmacist have to sit down with the patient, tell him about the duration, the dosing interval, the dose, and the need to complete treatment, so that we don't have people abandoning the drugs along the way and we promote resistance. I think these are the role pharmacists can play individually and collectively as a council, as a body. Thank you very much.
In fact, I couldn't agree more with Professor Samaila. We have downplayed the role of pharmacists, which is unfortunate. You know, what we need is, of course, in our center, we don't have pharmacists playing a strong role, but we have an infection control committee, who will tell us when not to use an antibiotic and when to use a specific antibiotic. In many Western countries, it's also the pharmacist who does that. Even if I prescribe meropenem, for example, the pharmacist can come down and tell me, look, you don't need meropenem for this. So we have downplayed the role. We've treated them as a second rung in the health professional industry, but really they should be coming up and telling the doctors, don't misuse antibiotics. I think Professor Samaila's point is very clear about that.
Exactly.
Right. And talking about occurrence of reinfection, what is the rate of occurrence of reinfection in Africa and also maybe on Asian side, Dr. Philip?
Dr. Philip.
So you asked me that, sorry, I missed that. We have data only from India, and strangely, such an important topic, we have only one article from India about reinfection rates. No published data for reinfection. So what I'm talking about from a public institution, these studies were done when I was in the King Edward Hospital, which is a public institution, a municipal hospital. There, the reinfection rate was 2.5% in a year, okay? But that's because Mumbai has exceptionally hygienic water supply at source. I can't say the same thing about Mofussil areas in India. So reinfection rates would be high. So it's no point talking about India as one country where 2.5 in a hospital in Mumbai would be applicable all over the country. We don't have data from everywhere. So obviously the reinfection rate will keep up with the infection rate, the prevalence rate. It all depends on your community hygiene.
I agree with you.
And Professor Samaila, what could be the occurrence rate if it is reported maybe for African countries or for Nigeria of reinfection?
I'm not aware of any documented published data from Nigeria, but I can't agree more with Dr. Phillips on the fact that as long as you go out there to the same unhygienic environment and unhygienic practices, the reinfection rate will be as good as almost the prevalence rate, because even if you have any confirmed eradication and you go back, you are not immune. This IgG is not protective. So you go and acquire swallow the bacteria again and still come down almost with anybody in the community. But I think we need to do a systemic trial in the country or multi-center to be able to document and follow up this cohort to see whether we can document officially and publish our reinfection rate.
Thank you so much. I think we have taken up most of the questions. They are not not taken up during the session, and few of them you have touched them, Professor and Dr. Philip, during your presentations. And I'm sure this wonderful exchange of insights from the two experts coming from two different regions would certainly going to help our audience in their regular practice. Thank you so much, Dr. Philip and Dr. Samaila, once again. I would like to pass on our sincere thanks to our audience for taking out your time in attending our webinar series. And I request you to please stay tuned to our updates so that you will come to know about the forthcoming webinars which we will plan. And the last but the most important thing that this webinar, it is accredited in some of the countries, and we are thankful to our CPD accrediting partners. And thanks again to the speakers and to DocMo team. Thank you.
Thank you very much.
Thank you, Professor Samaila and Dr. Thank you so much. Thank you. It was a pleasure, a privilege.
Thank you, Phillips.